This is part 1 in a two-part presentation on diagnosis coding and documentation to support billing for Medicare therapy claims. In part 1, the emphasis is on coding. At the conclusion of this two-part presentation, you'll be able to follow ICD guidelines to choose the most appropriate diagnosis codes for your therapy plans of care. You'll understand what elements are required in documentation to support therapy claims, and you'll be able to recognize coding and documentation examples that represent best practice. Information for this presentation comes from the ICD-9-CM official guidelines for coding and reporting and from CMS policy manuals. Legacy's policies and procedures regarding documentation, coding, and billing are written in accordance with CMS guidelines and regulations. The first, and sometimes the only, documentation of therapy services that CMS gets is the claim for reimbursement. The claim is the first communication with the payer, your first opportunity to share the story of the services you provide. And it's all done in code, starting with diagnosis codes. When a therapist assesses a patient, he takes into consideration all the factors that contribute to the patient's current condition and need for therapy. That information is documented on the therapy plan of care. It's written using clinical language and is represented by diagnosis codes from the International Classification of Diseases, or ICD. Those ICD codes are then transferred to the patient's billing claim, which goes to Medicare or another payer for reimbursement. The diagnostic codes are the first communication with the payer about why the claim should be reimbursed. They summarize what the evaluation and treatment documentation contain. It's up to the evaluating therapist to decide which diagnosis codes best represent the patient's condition and treatment focus. Some, but not all, Medicare administrative contractors, known by the acronym MACs, publish lists of diagnosis and treatment codes that support medical necessity. These lists can be found in the local coverage determination for therapy services. The specific condition for which therapy services are being sought should be represented by the most appropriate diagnosis code. Think of this code, usually referred to as the medical diagnosis code, as the medical necessity diagnosis code. Note that CMS guidance states that many, meaning not all, medical diagnoses will be relevant to treatment. It's not uncommon to review a patient medical record that indicates, for example, that the patient has diabetes or hyperlipidemia. Unless the condition impacts therapy intervention, leave it off the plan of care. Therapists don't treat diabetes or hyperlipidemia. These guiding principles come from the CMS Benefit Policy Manual. CMS directs therapists to bill the most relevant diagnosis, to use the ICD code that best relates to the reason for treatment. For example, when a patient with diabetes is being treated for gait training due to amputation, the preferred diagnosis is abnormality of gait, which characterizes the treatment. When a claim includes several types of services, or where the physician must supply the diagnosis, it may not be possible to use the most relevant therapy code in the primary position. In that case, the relevant code should, if possible, be on the claim in another position. Codes representing the medical condition that caused the treatment are used when there is no code representing the treatment. Complicating conditions are preferably used in non-primary positions on the claim and are billed in the primary position only in the rare circumstance that there is no more relevant code. For the next few minutes, we'll take a look at some of the areas that may be challenging or confusing when it comes to choosing ICD codes. Listen up, this is the good stuff. The ICD coding guide doesn't refer to codes as medical and treatment, but rather as primary and secondary. This can be a more useful way to approach code selection. List first the ICD code for the problem, condition, or other reason that has led the patient to seek therapy services. This code represents the primary reason the patient has come to you. Consider the functional issue at hand. Is it a problem swallowing, walking safely, or managing medications? Next, list additional codes that describe any coexisting conditions. An example might be pain in both knees that is contributing to difficulty walking. Pain would be an additional primary diagnosis. Personal history codes such as personal history of falls, V15.88, are also acceptable. Now consider how the patient's problem or condition will be treated. If a person has been falling because he's unsteady on his feet, the plan of care will likely address muscle weakness and gait. These are the secondary or treatment diagnoses. Here's an example from Medicare guidelines. We see a number of conditions and treatments for which we could assign diagnostic codes. The patient has diabetes, has had an amputation, and is receiving gait training because of an abnormal gait pattern. Is the therapist required to use all these codes? Can she use codes for conditions that aren't listed? To answer these questions, let's recall the guidance we've just reviewed. First, choose the most relevant codes, the ones that best describe the reason the patient needs rehab services right now. Second, consider what the focus of treatment will be and choose an impairment-based diagnosis to represent that. In this example, even though it's not stated explicitly, we can reasonably anticipate that the patient will demonstrate muscle weakness. That will be addressed in therapy. Muscle weakness is a contributing factor, so it would be used as a secondary diagnosis. The pyramid shown is one way of representing how we can separate multiple diagnoses to choose the best one for therapy services. The base of the pyramid shows the patient's underlying condition, diabetes. One of the medical consequences of diabetes for this patient was an amputation. As therapists, we're interested in the patient's medical history and status, but we don't treat medical conditions. We address function. Therefore, the most relevant diagnosis for therapy is the functional consequence of the patient's condition, that is, his abnormal gait. Abnormality of gait should be the primary diagnosis for this patient's therapy plan of care. This figure illustrates how to move from a broad, vague diagnosis to a specific one. Again, the therapist should think through the layers of information, from the patient's underlying condition of dementia to the medical consequences of confusion and anxiety, to the functional consequence of being unable to function independently because of cognitive impairment. That's the primary diagnosis for therapy intervention and can be represented by diagnosis codes for symbolic dysfunction or cognitive communication disorder. Here's a question that comes up now and then. Can I use the same ICD code for both the medical and treatment diagnosis? The answer is yes, you can. Most ICD codes used on therapy claims will have 5 digits, 3 numbers followed by a period, then 2 more numbers. Each digit after the period adds information to make the code more specific. Use codes with the highest number of digits available. Otherwise, the code is invalid and the claim will be rejected or denied. Let's look at an example. Joint disorders is the category heading. The code representing the category contains 3 digits, 7, 1, and 9. The 4th digit indicates the subcategory pain. The 5th digit indicates the specific location, shoulder. A different 5th digit would signify a different anatomical region. This is specific coding. A late effect is the condition produced after the acute phase of an illness or injury has terminated. There is no time limit on when a late effect code can be used. The residual may be apparent early, such as in cerebrovascular accident cases, or it may occur months or years later, such as that due to a previous injury. Here are some examples of late effects. Remember that there is no time limit for when a late effect is established, or for when a late effect code may be used. If a patient has late effects of a CVA, don't code for CVA. Choose the code that best describes the late effect. So, for example, don't use the code for a CVA when the treatment is for dysphagia as a result of the CVA. Use the late effect code. Let's look at an example. In this example, the patient has swallowing difficulties as the result of a stroke. The primary or medical diagnosis would be 438.82, dysphagia as a late effect of cerebral vascular disease. The secondary or treatment diagnosis is the specific type of dysphagia, in this case, oropharyngeal dysphagia, or 787.22. Therapists often wonder whether it's acceptable to use V codes. As long as the V code selected is allowed by the MAC, it's okay to use a V code. But what are V codes? V codes indicate a reason for an encounter. They may be used as primary or secondary codes. Be sure to check your MAC's local coverage determination before choosing a V code. Some commonly used V codes include personal history codes, such as the ones shown here. Next, let's take a look at how documentation supports coding. What does documentation have to do with coding? Everything. Every diagnosis code on a claim must be backed up by documentation in the medical record. And if documentation indicates treatment for a condition, the reason for that treatment must be represented by an ICD code. Take a look at a patient plan of care. Read the reasons for referral, the descriptions of the patient's medical history, and her current functional abilities. Now, look at the ICD codes on the plan of care. The codes should represent what's written in the evaluation and plan of care, and vice versa. If pain is documented as contributing to a patient's functional impairment, pain should be represented in the ICD codes. If strengthening is a goal, then muscle weakness should appear as a diagnosis. Let's look at some examples of documented reasons for referrals. The reasons for referral and the corresponding diagnosis codes were taken from actual patient plans of care. Do the diagnosis codes used represent the documented reason the patient's being treated by therapy? Let's look at example 1. The reason for referral is straightforward, and the primary diagnosis codes represent the issues documented. But look at the treatment codes. This is an OT plan of care. The written treatment plan didn't address difficulty in walking, so that code should not be on the claim. In the second example, the primary condition addressed in documentation is contractures. That should be the primary diagnosis. These are all good choices for treatment diagnoses. In the final example, you see when it's absolutely appropriate to use the same code for the medical diagnosis and the treatment diagnosis. The patient was hospitalized for an inflamed gallbladder, but the therapy referral is related to positioning. Cholecystitis doesn't belong on this claim. In this last example, the clinical information indicates that the patient was bedridden and had no appetite. This will lead to muscle atrophy due to disuse. the primary medical diagnosis. Therapists don't treat osteoarthritis directly, but osteoarthritis may be an existing condition which will complicate treatment, so it's okay. Debility is a vague diagnosis and probably should make way for the stronger treatment diagnoses included on the claim. These are good coding choices supported by the documentation. Likewise, the documentation backs up the coding choices. Let's review to see if we've filled the order for a better understanding of coding to support billing. Choosing the most relevant diagnosis codes lays the groundwork for reimbursement of claims. The ICD codes you choose may be the only clinical information a MAC sees in order to process a claim, so it's important to choose codes that describe conditions and treatments that are specific and relevant to therapy. Whatever codes are selected for a patient's plan of care, there should be documentation that supports that choice. Likewise, if documentation indicates a condition or a treatment that is relevant to the patient's plan of care, there should be ICD codes that reflect the condition or treatment. There's really no magic when it comes to choosing ICD codes for your patient plan of care. Remember to ask yourself these two questions. Why am I seeing this patient at this time? The answer will provide the primary or medical diagnosis. Think of it as the medical necessity code. Then ask yourself, how will I treat the problem to determine the treatment diagnosis? Finally, remember that coverage guidance from your area's MAC is a great resource. If you don't know how to access the local coverage determination from your MAC, ask your rehab director, area rehab manager, or area rehab clinical specialist for assistance. Use the information and tips from this presentation, and you'll be able to code talk with the best of them.